happy to be here with everyone today.
Good afternoon, all. And again, honored to be here and have this conversation. At the outset, a very brief introduction, though, if there's someone who hardly requires one, as the cliche goes, it is Dr. Preetha Reddy. She is the Executive Vice Chairperson of the Apollo Hospitals and, of course, a member of the founding family. And she is widely recognized for her contributions in making quality healthcare accessible to millions of people, not just in India, but in different parts of the world. Dr. Preetha is the managing trustee of the Apollo Hospitals Educational Trust, which is a body which steers the educational endeavors of the group. And she also works extensively with industry bodies, the government of India, to advance policy decisions on healthcare. In 2013, along with Dr. Pratap Reddy, she championed the establishment of NAT Health, which is the Healthcare Federation of India, which represents the unified and credible voice of Indian healthcare. She is also a governing council member of the International Hospital Federation, and she is an independent director on the board of companies, and she's also part of several social projects where she has provided leadership projects like Sachi, or Save a Child's Health Initiative. She's received multiple honors, including the Economic Times Businesswoman of the Year Award, Sir Jahangir Gandhi Medal for Industrial and Social Peace from the Xavier School of Management. She was also conferred with the Healthcare Personality of the Year Award by FICCI. So a round of applause for Dr. Preetha Reddy. Today's topic, cost of healthcare and the gap in medical education. I think all of us know that the quality of healthcare that we receive in India is patchy. There are centers of excellence that we know very well exist in the metros. And despite all the improvement that we've seen over the years, there are massive gaps in both access, affordability, and quality in many, many parts of our country. One of the problems that has been identified is medical education itself. In fact, that's where a lot of it is believed to start. So I could start this debate by getting or getting your inputs on what do you think are the primary problems with medical education in India as it stands today, and how some of these could be addressed.
Thanks, Sumanth. Really happy to be here. Very clearly, I think health and education are a fundamental right. You know, every citizen of India is entitled to good quality, at least good quality basic education and health. And I think, everyone has tried, particularly the present government at the center, by putting in multiple focus in investment, change in policy. So I think we are, in a way, on the right track. And, all of you are reading, and if you look at the NHS in the UK, sometimes I think they're in worse shape than we are in India. So I think we must be very cognizant of the fact that a country of 1.3 billion people, we really over the past 5 to 10 years are doing so much more so that the future generations have good access to healthcare. So, I want to be very clear on that point. The second is there is a problem as far as medical education. And when I say medical education, I don't want you to only think of doctors. We always do that. We think medical education means doctors. There's this huge workforce behind the doctors who are, who can perform well. And we must think and plan for nurses, allied healthcare workers, physiotherapists, nurse clinicians today. So I think we have to think a bit differently. And to me, that's a big challenge. We're living with the archaic norms, which, which is the British legacy. Until recently, if you wanted to do a medical college, you needed like 40 plus acres of land. You needed this much of building and infrastructure. You could only do 150 students. So there were so many norms put in which worked very well in the past. But if we're thinking future, forget about the past. You have to plan for an aging population. India wants to heal the rest of the world, very ambitious plans. Whether we like it or not, our nursing staff are waiting to go overseas because they make so much money. So there's all this which is in a way a challenge in the ecosystem. But we sitting here thinking future, thinking policy, trying to make a difference, have to see what are the 1 to 10 things we can do to make a difference. And I think change in policy is happening. A lot has happened, lots more to go. Change in mindset, because we have to think technology. We have to understand that you don't need 1,000 square feet to just take care of 10 people. You have to say 1,000 square feet will take care of 100 people. So I think these are the kind of thoughts which have to come into our mind. Challenges are there, everybody has them.
The cost of medical education has been a huge problem. I mean, governments are heavily subsidizing the cost of medical education for students, but the private sector, it costs around 20, 25 lakhs a year. And over a period of time, if somebody has to do a undergraduation and post graduation in the private sector in India, you end up spending around 2 to 2.5 crores. Now, this money needs to be recovered. How do you think this can be addressed? Because clearly one of the problems that we are seeing is that there is an explosion in private medical colleges. The government also feels that our doctor population ratio is not as it what should be, therefore we need more medical colleges. But then governments, except in states like Tamil Nadu, where we've done very well and opened so many medical colleges in the government sector, many states predominantly depend on the private sector. So, what can be done to sort of, this cycle has been going on for now 30 years. How do you think this can be changed?
I think things have changed, but you have to put a cost to anything. Everything comes at a certain cost. So if you want to have 1,000 beds, which technically are free beds or take care of that population of society, you still have to fund it. If you need infrastructure for housing, training, teaching, pay faculty, you still have to fund it. So all this comes at a certain cost. I mean, we should not charge to such a level that you're, raking in so much of money that historically it has happened. So I'm not saying let's not forget that it's happened. But going forward, for example, if you take the 2 medical schools which we run, if that helps, it is not a university, so it is with the local universities. And then there is a quota that 50% will be those who've passed NEET who get into it, and they pay 15 max of 20,000 rupees per year. So that is there. Then there's a second category which then pay a couple of lakhs a year. Then there's a third category which is 15%. You can change whatever. In a way, forgive me for this, but I think we're being like Robin Hood. Okay. So you're charging a certain population and trying to subsidize all that. Now, I personally don't think it's the right thing to do. Yep. You should have like a decent norm, and then give scholarships, give it to deserving students, have a system in place so that you do that. This way, it is skewed. So I really think India as a country is not getting the best. And unless people are able to fund these medical colleges and do it in a way which is transparent, which is practical, and in which you succeed, which means you bring out every year 200, 300 bright medical students who will be doctors of the future. I think that's the way we have to think of it.
But would you support the proposal which was there a few years ago for a 3-year quote unquote rural doctors? Because one of the major challenges is that there is doctors are concentrated in urban pockets, and rural India still does not have access to certainly specialists, not even super specialists. Even specialists are in short supply in rural areas. So would you support the concept of having the earlier scheme, which sort of has been shelved because there was a lot of opposition from the medical community, to have a 3-year program where you have doctors who are trained as primary care specialists? The cost would not be too high. They could be deployed in rural areas and so on. Would you support something like that?
See, we have to think differently. You can't force students who are studying in medical schools to go and serve for 3 years in a rural area, unless you're like the government of Singapore, which says that everyone has to be mandated to join the army. You can't do that. It's not going to happen. But I think you should encourage people, have a certain subject and a syllabus in the curriculum which says rural medicine is required, but they're not going to go for 3 years. Let's be practical. That will not happen. You can have a special subject for it and then say you become government employees to go and serve there. So I think we have to think a little differently. The current norms are not going to work, and you can't send somebody for 3 years into a village. They'll just run away. They'll give you
But the
excuses.
concept of a non-medical person, non-medical in the conventional MBBS MD sense, actually starting to deliver some basic level of primary care. Why is that not being looked on, or do you agree with something like that?
I I think it's going to become the norm because you're not going to be able to get away from it. But you need to train people to be like high quality scientific officers, which means you give them the basic anatomy, physiology, the whole medical piece where they know how drugs have to be prescribed and interact. And then use technology. I mean, India is spurning out the most fantastic future looking technology. You have AI, you have equipment, you have telemedicine. We really have everything. And I think we need to put that to use to serve the rural population. At least an underserved area then becomes served. And think like that. We serve Himachal, the highest locations in Himachal. We handle a crisis. We've done all that. We just have to scale it up and let the regulation open up in such a way, but keep oversight for outcomes. So think differently. You will see that the traditional MBBS won't go and sit in the rural
Do you
areas.
do you somehow feel that the healthcare industry itself is resistant to change? I know any industry is resistant to change, but the healthcare industry particularly seems to be resistant. I mean, there is technologies, for instance. You are aware, you're one of the early adopters of telemedicine, but most of this country woke up to telemedicine when COVID happened, even though the technology has been there for more than 20 years. So the why is it that doctors and the industry sees a challenge to revenue that makes them insecure? Uh, for instance, now the AI models which have come in, uh, why is there so much resistance to change? The Clinical Establishments Act, I mean, some of the rules there were so straightforward. It said that, one of the rules which doctors objected to was that you should have a hand wash area and a source of water supply in a clinic to wash, for the doctor to wash his hands. Otherwise, you're not supposed to be running a clinic. And even something as basic as this has been objected to. So, do you think that, one of the stumbling blocks in this entire ecosystem has been the attitude of the industry in some ways?
I don't know as much as attitude as, if you can communicate. Maybe we haven't communicated it right. Instead of saying you must have a hand wash, you'll have to say, listen, doctor, if you don't have a hand wash, they won't even look at you and say you're a doctor. Educate the patient. Let the patient say, where is the hand wash? I think the way we have to approach it has to be a little bit different. And I just want to give you a quick quote, which is Abraham Flexner. He's an American educator and a reformer in the medical education space. And to him, he says the purpose of medical education is not to fill the mind of students with facts, but to teach them to think and make aware of the fact that half of what they learn in medical school will be outdated in 5 years. So, that's where we need to come from, that a lot which we've learned in medical school, you can just Google it anyway. So why are you paying upwards of so many crores for that? It's in your palm top. So I think the mindset, the shift of clinging on to the past, that probably has to
And
change. And a lot of your answers will come from that.
yeah, and we know that very little has changed in the way medical education is imparted. And I can just take 10 seconds to tell you my own example. I mean, I did very well in my undergraduation, quote unquote, because if you judge me by my marks, then when I came into my internship, I realized that I didn't know how to treat a patient, even though I had awards and medals and so on. Then started the process of relearning the entire process, because we simply were not taught in medical education. in India how to deal with problems and how to deal with patients. We were told 100 causes of something, 200 syndromes, and all kinds of things which you would memorize, rote learning like many other specialities. And today we see that, 25, 30 years later, almost nothing has changed. We are still having doctors who are coming out who know very little about how to handle patients. The even more worrying part is that they haven't even seen too many patients, because many of the private medical colleges don't have patients. They have patients, by the way, in their registers. You will be interested to know there is now software that can cook up patients for private colleges who don't have enough patients. So that is the level to which we've gone. But coming back to this issue, do you feel that there needs to be a complete overhaul as far as medical education goes?
I definitely think that there has to be, in terms of content, in terms of the norm. NEET is good. I think they did a good thing by bringing NEET in. But the problem with NEET is that, we've so attuned to learning by rote. It's like you get your multiplication tables right, you'll get 100 on 100. You can't afford to have a doctor treating you who's learned by rote, who's, everything by going to those centers, coaching centers. That won't work for healthcare. And so that's the downside of NEET. If we can crack that, if we can give them a seat in medical school simply because we know that, their head and heart is in the right place, they really want, they're passionate about service and treating people, I think there should be some sort of a norm where you can interview them. Now, the back end of it is that, these things can be fixed, it can be fudged. That is, you can't run away from that, find answers for it. I completely agree. But I think the curriculum has to change. And I'm not talking for Apollo, I'm just talking about, how institutions can think forward. My dad is turning 90, so we thought the best present is to find a way to see that hundreds of millions of doctors in the country, the young ones especially, who are treating people, have some kind of access to information. So we brought out what is called the CIE, which is the Clinician's Intelligence
Engine.
Assist Engine. And that will give, for today it's for 80 different manifestations of clinical, so whatever happens, disease patterns, but it will go up to about 800 and much more. But this will at least give you the basics in hand, and it's going to be rolled out free to any doctor in a rural area running his own little practice. He just has to get into it. It's completely free. It's just a platform. Later on, it will probably be on their phones also. So I think the knowledge is there. There is AI. There is technology. If we can use it to reach the person and see that patients get the best out of it, it'll be a great thing. And tomorrow I'd like a day where people really don't go for unnecessary investigations. I know you were dying to ask me that question, so I'm saying it myself, that, armed with the right information, there's a lot which can be curtailed, which means healthcare costs can be put to the right use. We don't need to spend that much. The other issue which I think we have to quickly think about is one the pandemic taught us, how unprepared we are as a human, as a race. It also taught us that countries like India, because we came together so well, have risen in people's estimate. We were like totally up there, which other so-called developed nations were not. We have to be so proud of that fact. But the other learning is there's a huge graying and aging population. It's going to cost the world billions of dollars. If you don't change the way that medical education is, allied healthcare professionals are today, there's going to be a bigger problem. And there is nothing we're going to be able to do about it unless we think we should have done it yesterday. But if we don't fix it today, we don't change the syllabus, we don't change the norms, we really have a problem.
Yeah, and I think that is a huge challenge, because the thinking even from the NMC, for instance, what would you like your doctor to have? You'd like your doctor to have knowledge, information. You'd also like your doctor to have good communication skills. You'd also like your doctor to be compassionate. and you'd also like your doctor to be aware of the regulations that exist and so on. But except the first part, and that too patchily, none of the rest is actually taught in medical school. So they are sort of let loose on society to sort of find their way, as it were. What is it that prevents, and you would have interacted with the likes of the NMC and the MCI earlier and so on, what is it that prevents them from introducing IT skills, for instance, which today is a given, but 20 years ago it could have happened. India today, by the way, still does not have a mandatory law for an electronic medical record, which means that even in an outpatient setup, you are not required to maintain, as per law, at the doctor's end, a copy of what you actually prescribe. You can do it. Only for inpatients are you actually required to retain data. So what is it that prevents these things from actually happening in India? I mean, clearly these are policy issues which government can say 10-year time frame. It's been done in almost every developed country in the world. Why can't India do it?
Sumant, two things. One is the National Digital Health Mission is actually addressing a lot of this. So it's hard in a country where even literacy, it has to be in multiple languages in the first place. So I think the journey has begun, and there will be a backbone, a digital backbone with all health information coming, which again will help change the rules of the game to a large extent. And I think I'm confident it will cut healthcare costs for the country, because you will just find disease patterns. You will be able to do it so that data, when it happens, is it going to happen in the next 2 to 3 years? I don't think so. That's too ambitious. But it happens, 10 years will fly. If it happens 10 years from now, it's still a great win for us. So let's think about that. But where you need a law is to insist that people use technology. That is not there. You can get a license to practice. You may not be using electronic records. So even if you can access it, which is available, you're not mandated to do it. So to me, the problem lies there. And when we talk healthcare, I don't want us to forget the fact that the doctors are a large piece. They're always in the front of our eye. There's this silent workforce, which is the nursing
Nurses.
workforce. For heaven's sake, we have to do something for them, because that's why they're going away. They become nurses. They do because they want to go abroad and earn a better living and things like that. So what are we doing for them? We're not even thinking about that group of people. I think that's where
Yeah.
I
And I
want to
think
flag.
that, yeah, I think I agree entirely, because the nursing education area, there is no great excitement in starting nursing colleges even. For instance, in this state where we've had, now we have something like 35, 40 colleges in the government sector for medicine. There are hardly a handful of government colleges for nursing. And then there have to be, even private sector doesn't come in because it's not that high a revenue earner. And by the way, nurses spend, it is estimated, 10 times more time with the patients than the doctors do. So we have to understand that they are the backbone of the healthcare system, rather than just the doctors. One controversial
Icing
question.
on the cake, budget announcement was 157 nursing colleges.
Nursing
I
colleges.
wish there was another zero next to it and it was 1,570.
Yeah.
But having said that, that's what keeps me awake in the night, to think that, yes, even if I look for data, it's all about this many doctors, this many medical colleges, so on and so forth. If I ask for data saying how many nursing colleges are there, public sector, private sector, they have to search for it. And that's a worry, that nowhere in the world are we thinking of this workforce. They take on 50% of the burden. And I'm not talking India, by the way.
Global.
UK wants shiploads of Indian nurses. Australia wants, Canada wants, the UAE, they're going anywhere. So what are we doing?
Yeah, absolutely. One controversial question: do you support medical education in regional languages? Now that's a big push by the government. I mean, in fact, now they've introduced medical education in Hindi. They want regional languages also to follow. I mean, state governments have been told you're welcome to open medical colleges in your states in the regional languages. Does it make sense? Because one of the things is it's been said that such a move would make medical education more accessible and thereby inherently have a cost impact in terms of bringing down cost.
So, plus and minuses. You could get a medical degree in France and only speak French. So why not? Some of our states are larger than France. So that's one side of your question. The second half of it is that the portability issue. Let's say in Oriya, let's say you do everything in Oriya. Can you really access all that language? Do we have search engines which will come back and give you that kind of language in your language? I'm not equipped enough to answer that. So you have to think it through a little bit. So the ethos is fine, but the practicality doesn't seem to be there yet.
Okay. Couple of questions from the audience, and then we'll have to. Yeah. Yes, sir. Please.
So, ma'am, a few sessions ago, we had people talking about utilizing metaverse as a medium of medical education. And the truth is that this idea is actually being implemented in a lot of parts in the world. But my question is, like, do you think that these developments will add to the cost of medical education vis-a-vis the quality of the doctors that are being produced? And will these developments be feasible for a country in terms of the quality of doctors and in terms of the increased cost and the limited accessibility that we have?
So it should not add to the cost, then it's self defeating. We should be able to use technology so that you can keep the costs within that budget. So that's very important. There's no going away from the fact that you have to use the metaverse for knowledge, for training, because some of the best training, if you want to train from somebody, let's say in the US, you can go on that, you can use it. So why would you not? Today, they're training people to use robotic surgery using 5G technology for somebody in Assam. Nothing wrong with that. So I think you have to be smart and intelligent to use the metaverse to make them better clinicians. And there is knowledge in multiple formats. So why would we not use it?
And just to add to that, there are at least half a dozen companies, startups that are working in purely metaverse for healthcare, and including many in Bangalore. So there's a lot of work which are going on. Avatars of doctors are being created, and some of them are it's extremely exciting. I had the opportunity of seeing a couple of demos. We're not there yet, probably a couple of years down the line, but it's happening.
Another thought I want to, place with you is all the IITs are starting medical schools.
Oh yeah.
So there's a convergence between engineering and healthcare. And this is happening because now we're thinking like that. So you will see a lot of changes happening in healthcare, including the fact that you'll have intelligent devices which will then tell you where you are, how you are you going to get a heart attack? Somebody in this hall sitting is, potentially might get one. I God forbid, I don't want anyone to. But I think all this is going to happen. And are we going to grab that for the betterment of our country and our society? We should.
Yes. Next. Just two more questions, please.
Good morning, everybody in the audience and the people who are sitting on the stage. I would like to start up by addressing the crowd. Jai Sri Mataji. I am addressing the problems, what all has been narrated here in this hall. You can go in for free medical treatment by treating yourself, by awakening the cosmic doctor which is within you. That is, please log on to www.sahajayoga.com.
So, any specific questions, sir, please?
No, this is what I wanted to convey.
Yeah.
I'm answering all your problems will be solved if you log on to www.sahajayoga.com. And all your answers are answered, and everyone can treat himself absolutely free.
Okay. Thank you, sir. Thank you. Yeah, we'll take the gentleman at the back. Yeah, the lady, and then the gentleman at the back last. Yeah. Yes, ma'am.
Good afternoon, ma'am. Good afternoon, sir. My name is M. Sneha. Uh, as the doctors and the frontline workers or nurses, as you said, are considered as the most service, noble service, why take a step back when they have to serve for a rural background people where the service is much needed?
Why are they reluctant to serve in rural areas?
Yes.
So I think this is a problem. Let me tell you the problem we have. It might help. We built a beautiful hospital in Karakudi, which is near Chettinad, near Madurai, and we built a beautiful hospital in my dad's village, which is Aragonda. But for both those, we're not able to really get somebody to move like a super specialist from the city to go there, because they have children, they need schooling, they need a social life, they need to go shopping. There's so many things. You can do it for 6 months, you can do it for maybe a year, but it's hard because you need the surrounding of the city life. Now in Aragonda, which is again my dad's village, our super specialist knee transplant surgeon has done 500 knee replacements, not a single infection. So they've gone there as a team. They work for 24/7 for a whole week. They do, and you get the outcomes. So I think we shouldn't be fixed in our mind that the specialists will really give up everything and go and live in the rural areas. It's a bit hard. From sheer experience, I'm saying that I don't think that will happen unless the rural areas also give you that kind of a city life.
Last question. Yeah, the gentleman at the back.
Hello, my name is Nitin. Thank you for the talk. So, we were discussing a lot about medical education in university. So, I want to take a step back. A lot of students from school, for example, who get into the medical education line come through influence from their parents. So, there are so many young minds who are thrust into this line against their interest. And the irony is that we don't have enough doctors and not good doctors also. So, to some extent, this requires counseling. But how do you generate interest in high school students to pursue this as a profession apart from just selling, be a doctor? Like, what is it about the study itself that can make them enthusiastic about being doctors?
You're younger than me, Sumanth. Do you have an answer?
No, I've got a very difficult answer to that. Look, today if you go and check the families of doctors who do not have nursing homes or hospitals, my gut feel is that 80% have asked their children not to do medicine. So I think that there is this pressure that you talk about that comes predominantly from parents who have invested in a healthcare setup. They have either a very large practice, or they have invested in hospitals or healthcare infrastructure, and therefore they want their children to get into that. Otherwise, most doctors, in fact, the joke in our batch itself is that the vast majority of our batchmates kids did not choose to do medicine. Those who did are those who generally had hospitals. So I think that that is changing. But your question of what needs to be done in schools, yes, aptitude has to be assessed. Right now we are not assessing the aptitude at all, but parental pressure is not as big a factor as it used to be in those days, because multiple options are available. In the earlier days, you either did engineering or you did medicine. You didn't have too many other options. Maybe you did law, one or two other things, but that's about it. Today you have 100 different options, so opportunities are there. So the pressure comparatively is a little less. But yes, counseling, aptitude assessment, we are not even doing that at a basic level. Assessing what is the child interested in, what does the child have an aptitude for, and therefore could he or she pursue that. We're not doing that. Perhaps that would be a good idea.
No, I totally agree, because it was you either had to be an engineer or you had to be a doctor. And now it's like, you have to be like in software and find a way to go off to California. That also, parents are pushing in that direction. Then financial services. I think today it's much better to be an investment banker. It's cooler than to be a doctor. So I think it's changing, and we have to understand what the future students want. And today is not the day to really force them to do anything. We'll have unhappy doctors, which is scary.
Yeah, I know. And healthcare is at a tipping point. It's my very firm conviction that we are, maybe 3 to 5 years away from a massive disruption in healthcare. I know that many may not agree with this, but people like us who've been in the healthcare IT industry for a long time feel that we are probably 5 years away from a major disruptive change in not just medical education but healthcare delivery itself. So I think it's been a very interesting session. Thank you so much for sharing your thoughts with us. And so many fascinating insights have come from it. Once again, thank you for being here today.
Thank you, Sumanth.